Hello, everybody, and welcome back to Hybrid Healing Hour. Today, we're going to be talking about male testosterone therapy. And I believe this has been a big hit these days and a very big topic of discussion in our office and elsewhere. I mean, there's tons of books out there and other podcasts about this and tons of clinics popping up that do hormone replacement therapy. So I know you like to talk about history, and why don't you go ahead and tell us a little bit about testosterone and what is it?
It's true. I love history and knowing the history behind things. So first, testosterone is a sex hormone. So hormones are the body's chemical messengers. They tell our different organs what to do and our different systems what to do. And we always talk about how cholesterol is bad, but cholesterol is actually necessary for a lot of things, and testosterone is actually synthesized from cholesterol. Now, going to the history of testosterone, testosterone itself was named in 1935 after Ernest Lacker isolated from bull's testicles in Amsterdam. And why bull's testicles or why testicles? Because we know that there are blood levels of testosterone. And typically, the levels of testosterone in the testicles are about 10 times higher than they are in the blood itself. Modern androgen, which testosterone is an androgen, but modern androgen therapy began when testosterone was chemically synthesized in 1935 by Adolf Butenandt and Leopold Ruzica, and I'm sure I butchered both of those names. Early on, after they found testosterone, it was discovered that oral testosterone was ineffective. And we know that that's because of first-pass metabolism, which we'll talk about a little further. But the first actual usable form of testosterone were testosterone pellets. In the 1950s, injectable testosterone enanthate became widely available and was a preferred route for testosterone administration. And testosterone usage has actually tripled in the United States between the years 2001 and 2011. And since then, it's gone up even higher. Like you said, there's clinics popping up everywhere that do testosterone replacement. So testosterone is produced in the gonads by the Leydig cells in the testes in men and in the ovaries in women. And although small quantities are also produced in the adrenal glands in both sexes. Testosterone levels are greater in men, typically 10 times higher than in women.
And yes, to our listeners, women do have testosterone as well, but that's for another podcast. And so testosterone helps with many functions of the body in men. And so it helps them maintain bone density, the fat distribution, muscle strength and mass, along with facial and body hair, red blood cell production, sex drive. I'd say that's probably the biggest one. That's a key, trigger for people to inquire about. Sperm production, as well as maintaining a role in their mood and stabilizing mood. It goes hand in hand with feeling irritable, and also a role in, like you said, the lipid metabolism, which has to deal with their cholesterol.
And even though people think of testosterone to be largely responsible for erectile dysfunction, and as a general rule, we find it's not exactly true. Maybe about 10% of erectile dysfunction is testosterone related, and a lot of it is vascular. So testosterone's role in aggressive behavior is largely a myth. I know we've all heard about roid rage and people taking testosterone to become overly aggressive, but typically that's not the testosterone to blame. That's typically more estrogen and the blockage of estrogen that people do. But testosterone does help balance the mood.
And think of this as well. I mean, testosterone is also, I get asked the question of what's an anabolic steroid? So you hear about like the roid rage is more with anabolic steroids. Well, testosterone is technically an anabolic steroid, but it has to deal with the amount of people injecting and whether they actually are using it for low testosterone as we use in the medical field or if they're abusing it. So that is the difference.
And anything can be abused, and plenty of things are abused. So what are some of the symptoms of low testosterone? We get people come to our clinic all the time saying, I think I have low testosterone. We always say, well, why do you think you have low testosterone? So the more common ones, symptoms that people have are things like fatigue, weakness, moodiness and irritability, depression, hot flashes. Believe it or not, men have hot flashes too. I think they call it andropause. So sleep disturbance, testosterone deficiency can actually worsen sleep apnea. It decreases motivation. It can cause brain fog.
As well as losing muscle, as we mentioned before. I notice a lot of times people, say they're going to the gym, they're working out, nothing has changed, but they're not able to maintain that muscle mass that they used to be able to, as well as decreased libido, which is the actual sex drive. The erectile dysfunction, like we mentioned before, it can be a side effect of that. It not necessarily is, but also if you have low testosterone, that is also decreasing your erections in general, or your ability to perform. It can be associated with that. Osteoporosis, which is thinning of the bones and putting people at increased risk of fractures. And yes, we think about this with women a lot, but it can definitely happen with men.
Many men don't know that they should be having bone densities as well. I mean, it's common for women to have bone densities, but men probably at the age of 70 should start getting bone densities. Unless they had a fracture, then they should get it done sooner.
It also affects the hair production, so it can reduce facial hair and body hair, as well as testicular shrinkage and infertility issues. Gynecomastia is, I typically see that more with hormone replacement therapy, but it can also happen when your hormones are off. And when you have low testosterone, it kind of has more of an effect with the estrogen at that time. And lipid and cholesterol abnormalities. So we see all of a sudden people can have high cholesterol on their labs. And why is this happening?
So why do people have low testosterone? Why are testosterone levels so low right now? And I think they're at this current stage of time, they're probably the lowest we've ever seen. My theory is that if we were able to draw testosterone levels on people several hundred years ago, or even let's say go back 100 years ago, we're going to see remarkably different reference ranges. We're going to see numbers that are significantly higher than now. And unfortunately, there's no way of really going back and checking people's levels from that time period. And I think that's largely because of what we've done to our food supply, what we've done to our environment, what the toxins we're exposed to. Men typically have a normal decline in testosterone levels as they age. And men start losing about 1% to 2% of testosterone per year once they hit their 30s. And in some cases, it's more rapid than that. I have had patients that I've seen, and I'm sure you have as well, who come to us in their 30s and have testosterone levels that are in the 200s, extremely low. So why else? What other causes are there?
Well, as you already mentioned, it does actually have a lot to do with what we put into our body. The food choices we make. We're eating worse quality of food and making poor choices of food. A lot of people are always in a hurry. They're busy, so they stop and they get fast food, which is highly processed. And involving that, we're also putting more processed phytoestrogens in our body, which are estrogen-like compounds derived from plants. Those are foods that actually can increase your estrogen levels. So, and it's not all of them. So soy, lentils, there are good phytoestrogens out there, but it's the highly processed ones. So if you're getting them from a fast food chain or it's the quality, right? It's that really impacts it. And also it's the other toxins we're exposed to, which we've talked on other podcasts about, the toxins in our everyday life from plastics and fragrances, even smoke, all of those can definitely affect. And stress levels everybody's stress levels these days is so high compared to what it may have been, 50 years ago, as well as exercise. How many people out there are not moving these days that they need to? We use cars for transportation. Hardly anybody's out walking, bicycling, or even just hitting the gym. And it doesn't take a lot. Actually, one of the things that I always educate my patients on is you will get the biggest bang for your buck with 15 minutes high intensity workout, and especially working out the lower body with resistance training. That is very critical. You don't have to hit the gym for an hour and lift an hour of weights every day. If you could just do 15 minutes of resistance training, and especially the legs, you can increase your testosterone.
And in this country, obesity rates and BMI is increasing drastically, and you can correlate the decline in testosterone levels with the increase in overall BMI. Sleep apnea rates are increasing. We know sleep apnea can cause low testosterone. Chronic pain medication use, especially opioids, can cause low testosterone levels. We have patients that we see who are on chronic opioids like Percocet, and their testosterone levels are very low. And marijuana use is increasing in this country, and marijuana has been linked to low testosterone levels. We don't know exactly what the mechanism is, but I have a feeling that because we know that marijuana can also increase the rate of gynecomastia, it has something to do with the conversion of testosterone to estrogens, which is probably the underlying cause of why marijuana decreases estrogen levels.
So if somebody comes into the office and they are interested in having their hormones checked, what are some laboratory testings that we check?
Okay, well, we can start with the standard testosterone level in the blood. Testosterone in the blood is mainly bound to serum proteins, with only about 2% of the hormone is circulating as free testosterone. Sex hormone binding globulin, which is also called SHBG, accounts for about 60% of the testosterone binding. 40% is bound by albumin or other proteins. Bioavailable testosterone, which some labs will actually measure the bioavailable testosterone, free testosterone, and total testosterone, but bioavailable testosterone refers to the free testosterone plus the albumin-bound testosterone.
And I always advise for testosterone to be best checked first thing in the morning on an empty stomach between 8 a.m. and 11 a.m. ideally. If you can do between 8 and 10, even better. And this is because of the way that testosterone works on the circadian rhythm and the testosterone production by the testicles.
And one of the things that can cause low testosterone are things like pituitary tumors. So we will sometimes check a prolactin level, which can be measured to screen for possible pituitary tumors, such as a prolactinoma, as a cause of male low testosterone. And then we've mentioned this before many times, and we'll say it again. Reference ranges, which are the values that most people say are the, quote, normal values, do not equal optimal ranges. I would not go by reference ranges, high or low, because the reference ranges for testosterone are all over the place. I would go by what is optimal.
I couldn't agree more. And so let's talk now on the history of testosterone treatment therapy. So one of the methods that we use most in our office is pellet therapy, and that actually was first discovered or started being used in 1939. Pellets are still one of the most effective treatment options, and that's why we like them most. It has more of a steady state and for longer duration, and it's actually easier for compliance as well. And I think people just feel better with them. But overall, many patients and physicians out there are unaware that this even exists. And I love when people are like, oh yeah, those pellets, that's a new thing, right? I'm like, actually, that was one of the first treatment options.
When we started doing pellets in our office, which is many years ago now, nobody had ever heard of them. Patients had never heard of them. Most of the patients who went to see other doctors, their doctors had never heard of them. Now they're becoming more widespread. Now I would say a large majority of our patients have either heard of them or know someone who is on pellet therapy. It's still more common to see pellet therapy being done in women than in men, maybe because they need a lot more pellets and a little more tricky. You really have to have some expertise in doing pellets in men, but it's starting to catch on. Testosterone first got a bad name with the development of oral 17-alpha methyl testosterone, and that was found to be hepatotoxic due to problems with something called first-pass metabolism. So what is first-pass metabolism? It's when the drug has to go through the liver first. It gets processed in the liver, and then it gets converted, and the liver will pull some of the drug out and maybe convert some of it so that it's usable, but some of it becomes toxic. And so we did not use oral testosterone for the longest time because of the hepatotoxicity of the drug when it went through first pass metabolism. And that's still why most of the fear about testosterone is there, because of that original finding.
And testosterone propionate was the first injectable discovered and used, but it has a short half-life. And so it is still used today, not maybe as commonly as some of the other forms we'll talk later on.
And then came testosterone enanthate. In 1954, it became the most popular testosterone preparation for almost half a century, and it has a fairly long half-life. Then in the 1970s, a safer and more effective oral preparation called testosterone undecanate, and I'm sorry I said that wrong too, was developed. and it was absorbed through the gut via the lymphatic system. So it avoided the first pass metabolism effect in the liver where it goes through the blood system.
So we've talked about the history. Now let's talk about different options out there. So when we talk about testosterone, there's many different types, as we've already mentioned a few, but tell us how it's made and how it can be so sustainable, and the half-life of these medications.
Testosterone now is usually derived from plant sources, and typically it's plants like yams or soy. And that is both the injectable testosterone and testosterone pellets. When we talk about half-life, the half-life of a drug is the time it takes for the half of the drug's active substance to be reduced. Okay, so every drug has a different half-life. And typically after 4 to 5 half-lives, the plasma concentration of a given drug is below clinically relevant concentration, which means that pretty much all the drug has been eliminated from the body, probably about 97%. Testosterone esterification, that's where natural or unmodified testosterone cannot be injected on its own because it only has a half-life of about 10 minutes. So they have to convert that testosterone into something that's going to last longer in the body because nobody wants to give themselves a shot every 10 minutes. So injectable testosterone has been modified by a process called esterification, which adds an additional side chain to the testosterone, prolonging its activity. And the length and structure of the side chain usually determines its half-life. And the acid that they use for the formulation gives its name. So that's where you get the enanthate, cypionate, and the others.
Okay. And so now we can talk about the adverse effects, right? So a lot of people there is a fear of testosterone therapy for some people out there. And I think the most common one that I see is what we call secondary erythrocytosis, which is, I'm going to say, AKA thick blood. So some people are worried that having thick blood is going to lead to, increased clotting or risk factors that I want you to discuss. But this can be treated easily with periodic blood draws or blood donations. I know that, or what we call therapeutic phlebotomy. And the long-acting injectable forms, the cypionate and the enanthate, tend to have the highest associated risk with erythrocytosis.
Erythrocytosis is generally defined clinically as a hemoglobin greater than 18.5 or a hematocrit greater than 52 in males. And some of the potential mechanisms of why we get erythrocytosis is decreasing something called hepcidin, binding iron, and erythropoietin, which is a substance a hormone that tells our body to make blood. But there's many factors as to what causes this, and not everybody gets it. So we have plenty of patients on testosterone therapy, and not all of them develop an erythrocytosis. And the problem with this is that increasing viscosity of the blood increases the risk for potential vascular complications, including heart attack, stroke, and decreased peripheral vascular circulation. But actually, when you look at the literature, there's limited evidence that actually supports a relationship between testosterone replacement therapy and vascular complications like stroke or heart attack. Now, there are other disease states that cause thickening of the blood, something called polycythemia vera, and that's different. And in those people, there is an increased association with heart attack and stroke and thrombosis.
And some other possible adverse effects would be fluid retention. What happens is you accumulate water, and benign prostatic hyperplasia, which is also known as BPH, which means you can have benign enlargement of the prostate from hormone replacement therapy, as well as gynecomastia, which is actually an overdevelopment of breast tissue. And that's something that I think a lot of guys are afraid of having that. And sometimes that would have to be surgically removed and taken care of. But that's something we monitor. Hepatotoxicity you've already touched on, and that's usually with the oral forms due to the first pass. And acne, some people also, get backne where they have, acne on their back. And testosterone therapy can also cause the testicles to get softer and smaller, which some men don't like that either.
And that's just a side effect of the way the testosterone works. So we are able to typically mitigate that a little bit by putting people on a supplement called DIM, which we'll talk about a little bit later. So some of the other things, it can worsen obstructive sleep apnea, although we don't understand the cause of that, and the evidence is poor. But we know that low testosterone can also worsen sleep apnea. So it's hard to say what the relationship is. Infertility is a problem because testosterone therapy causes a loop where the brain tells the testicles to make less testosterone. And in addition, the testicles also make sperm, so they make less sperm. There's no evidence to support testosterone as a cause of prostate cancer, but there is some evidence that testosterone treatment may adversely affect the progression of prostate cancer. So typically, if someone has active prostate cancer that they're being treated for, we do not use testosterone therapy, but that is not to say that we won't treat someone with testosterone who has a history of prostate cancer. We just do it very carefully.
And monitor closely. So there's many forms of hormone replacement therapy with testosterone. Some of the forms are creams and gels, and those are pretty easy, but some of them can be messy. And so we have androgel, Axiron, which, and they're basically, they kind of get their name, like Axiron goes into the armpit, which is also known as axilla. And Fortesta, Androderm, Testim, and then there's also compound gels. So a lot of these are made with alcohol base and can be quite runny, but they're made with alcohol so they can get absorbed, and then that way they dry faster too.
I think androgel is the one that most people know, and that's because they had very good marketing. Doesn't mean that they were any better than the others, but I mean, there was a time where you couldn't not see an androgel commercial on TV. Everyone was talking about it. Axiron is one of the messiest drugs I've ever seen. You have to pour it into a cup and then hold it under your arm until it gets absorbed. I don't know anybody who really liked that one.
And then there's also injection therapy or shots. And so there's subcutaneous that is this one's fairly new. And it's a Zyosted auto-injector, and that's a once-a-week injection subcutaneously in the stomach. And then intramuscular injections are more common, which are meaning an injection into the muscle. And we'll go through the different types there are, and that's testosterone and enanthate. Let's start with that. So
enanthate is a synthetic androgen ester derivative of testosterone. And these injections are what we call depot injections, which means they form like a storage unit in the fat, in the subcutaneous tissue. And they release gradually. So enanthate has a half-life of about 4.5 days and a mean residence time of about 8.5 days.
So it's typically made with sesame oil and grapeseed oil, and it tends to be a cheaper option than cypionate, but this is more commonly used in Europe more than the U.S.
And many hormone replacement clinics report a faster onset of action than cypionate, but a shorter half-life. So it requires more frequent injections. Some patients report a rapid jolt after injection because of the faster onset. And the typical dosage is about 100 to 200 milligrams injected intramuscularly once or twice a week.
Then there's also testosterone cypionate,
which is a synthetic androgen ester derivative of testosterone as well. And the half-life of that one is about 8 days. It's about 65% bioavailable.
The brand name is still available at pharmacies, but it's widely available at lower price through compounded pharmacies.
And the typical dosage of that one is about 100 to 200 milligrams every 1 to 2 weeks.
And this is also typically mixed or compounded with grapeseed oil or cottonseed oil. Then we have testosterone propionate.
And that one is rarely used because that one has a very short half-life of about 4.5 hours.
It's injected about every 2 to 3 days.
The nice thing about that one, why some people like it, is it can potentially create more stable blood levels because it's used more frequently. You don't get the roller coaster effect that you get with the longer-acting testosterone esters.
And this one is usually mixed with olive oil based. So testosterone suspension.
So that's one that hopefully you never use. That's a dangerous one, and we really don't recommend it. It's used by bodybuilders to quickly build muscle mass and strength, and it's usually available on the black market, not through a legitimate provider.
And power lifters like it because it can kick in quickly within about 1 to 2 hours.
Yeah, it's a water-based testosterone. The shots are very painful. It is pure testosterone. It's not a testosterone ester. It's got a very high rate of aromatization, which means conversion to estrogen. And there's really no true half-life because it's immediate. It works instantly.
Pellet therapy.
That's our favorite. So we really like pellets in our practice. It's convenient. It's safe. You get consistent levels. But there's many pellets available and many different brands of pellets. The one that is typically prescribed through and covered by traditional insurance is Testapel. That's a pharmaceutical pellet that is FDA approved. It is a synthetic crystalline testosterone, and it's the brand that probably most of the urologists use. We don't really like that one ourselves because the doses are kind of low. We don't get people to optimal levels. We can raise their levels, and some people will get to optimal levels, but the vast majority of people do not. And in our experience, we've found that patients who've been on Testapel and then been on more of the compounded pellets prefer the compounded pellets.
And most of the compound pellets are bioidentical, which are derived from wild Mexican yams and soy. So they're the closest thing to our natural testosterone levels.
And as we said, men require more testosterone, higher testosterone dosages than women. Typical testosterone pellet is 200 milligrams, and a 200 milligram testosterone pellet releases testosterone at a steady rate of about 1 to 3 milligrams per day. And what we do, because we calculate their dose precisely, we figure out how many milligrams total they need, and we just keep adding pellets until we get to the dose they need. And so several pellets can be inserted at the same time to increase the dosage. And the dose is typically determined by the surface area of the pellet. So the pellet releases gradually until it's completely dissolved and gone.
And when we say pellets, we're talking about these little rice pellets that, they look like candy, kind of.
Yeah, in men, they look about like a long, skinny Tic Tac.
Yes. And in men, pellet therapy usually works for about up to 5 to 6 months, and then they come in and we do another round. And in females, it typically lasts for about 3 to 4 months. Now, the most common complication from pellets is something called an extrusion, where the pellet can try to weasel its way back out of the body. And that's a pretty simple fix in our, in the clinic in no time.
And we don't see it very often, which is good.
Yes. And it's actually minimal pain if it's done correctly. The procedure is a very quick in and out procedure.
And there's many companies out there now making compounded testosterone pellets. And, I can't speak for all of them, but the two of the brands that we trust a lot are a company called BioT, which has probably been around the longest, and a relatively newer company called Evexapel. We find that they are safe, they're consistent, and we really like to use those in our practice predominantly when we do pellet therapy.
Now, there are 2 oral testosterone therapies out there that they say they do not cause hepatotoxicity. Tell us about them.
Yeah, so now these new formulations don't go through first pass metabolism because they're not absorbed in the bloodstream. They're actually absorbed in the lymphatic system. So one is Jatenzo, and that's a twice-a-day medication. And the other one is Tilendo, which is 2 capsules twice a day. And they have to be taken twice a day because, again, they're not long acting. They're very short acting, and you don't want the roller coaster effect of these medicines.
And then intranasal.
I think there's a few intranasal suspensions, but the one that we know the most is probably Natesto. We don't really use intranasal much in our practice. I never found that people really preferred that over any of the other routes. Like I said, most of our patients prefer pellets, and they're very happy with their pellet therapy.
And one thing, another option is when you go through a compound pharmacy, you can also get it in a troche form or a rapid dissolving tablet. And these are other things which are very similar to the oral, but you just don't swallow it. You dissolve it in the buccal mucosa of your cheek or under your tongue or on your tongue. And that also gives you, like you said before with the orals, almost like a peak and trough. And so, you get that spike of testosterone from that throughout the day, but then by the end of the day, it's worn off already. And testosterone already has that natural pattern. It has that, what we call the sawtooth pattern. So as I said before, when we check the blood work, you want to check it first thing in the morning because testosterone rises overnight. And that's exactly why there's a direct correlation with sleep apnea, I believe, in the circadian rhythm. So testosterone rises overnight, and then it depletes during the day. And so that's what we call, and then it does it again. So it's kind of this sawtooth pattern. So when you take your testosterone troche in the morning, then by the end of the day, it's wore off again, So that's why I am also a fan of the pellets or, more of a sustainable, longer acting form. Now, there are so many questions that we get every day, and I want our listeners to feel free to always message us, email us, or DM us on our socials. If you have any questions we could answer. But let's talk about how long would somebody have to stay on hormone replacement therapy once they start?
I think the answer to that is as long as you want to keep feeling good. If you're feeling good, I don't know why you would really want to stop taking it unless there's a good contraindication for the medicine. But we have patients in their 80s who are on testosterone therapy and they feel good. They feel vibrant. And nowadays, age is just a number. Most of our patients are fairly active. They're playing golf. They're out there. People still have a great sex life well into their 80s and even beyond. So the answer to that question is there's no reason to go off of it unless you want to go off of it, and you can stay on it indefinitely if you want.
And who should be considering hormone replacement therapy?
Anybody who wants to feel better. We don't believe that you should just target your numbers, right? The lab is a good tool and it helps us. It tells us if your levels are low or not, but we have plenty of patients who come in with fairly low testosterone levels, but they feel great and they look great and they're healthy otherwise. And we tell those people, well, I don't know that there's any good reason just to treat your numbers and not to treat how you feel. So we find that people who are symptomatic really should think about it. And it's, again, we said before that you can stay on it forever, but you can also go off of it anytime you want. So if you do it, I recommend if you're going to do pellets, you do at least 2 rounds to really see the true effect, because the first round may not completely get you to a steady state. But after the second round, you should know, is this helping you or not? And sometimes we have people who tell us, well, I didn't really feel much different. And then they go off and they're like, oh, wait, yes, I did. It made a difference. So symptoms are what I would go by. And
just because, like you said, I always say we don't like to treat the number, right? So, I mean, if you're symptomatic, but your number is also, 850, it's probably not the testosterone. That's your problem. So we'd have to dive in to figure out what else could be causing your symptoms. What about heart disease? You touched on this before, but can testosterone cause or worsen heart disease?
We have plenty of friends of ours who are cardiologists, and we used to have this argument a lot in the beginning, where they would try to take our patients off of testosterone because they believed it was bad for the heart, that it increased their risk of heart attack and stroke. I think that's been fairly disproven now, and several studies have come out saying that is absolutely not true. The European Heart Journal a few years ago came to a conclusion that low serum testosterone levels were associated with an increased risk of all-cause mortality independent of typical risk factors. And that serum testosterone levels were inversely related to mortality due to cardiovascular disease and cancer. So what is that saying? To summarize, it's saying that low testosterone carries an increased risk of heart disease. Replacing testosterone has not been found to do that. And as long as it's done safely and under monitoring and supervision of a skilled practitioner.
All right. And can testosterone replacement therapy cause prostate cancer?
So it's weird how that came about in the beginning. The bottom line is no, it cannot cause prostate cancer. The initial study in 1941 by Dr. Charles Huggins and Clarence Hodges found that castration resulted in regression of metastatic prostate cancer. So they used this finding to imply that androgens like testosterone were involved in prostate cancer growth. This was a flawed conclusion because it takes very little testosterone to affect prostate cancer.
And I think it's also very important to obtain a baseline PSA, which is a blood test that we look at to monitor your prostate enlargement, I guess you would say. And this is, obtain this before you initiate any hormone replacement therapy. And then we also like to monitor this closely, a minimum of every 3 months, 6 months, and then yearly.
And typically we do a workup. If the PSA rises over 4 nanograms per milliliter, if the PSA rises more than 1 nanogram per milliliter in the first 6 months, or if at any time the PSA velocity rises more than 0.4 nanograms per milliliter per year.
So what happened to the old adage of if it doubles in a year, that's of concern?
Yeah, I think we look at other things now because many things can raise PSA, and we know that. Riding a bicycle can raise PSA. There's so many things, and we've talked about that in a different episode. Men with low endogenous testosterone levels have increased rates and severity of prostate cancer at diagnosis, and this includes all types of prostate cancer. And available evidence supports the overall conclusion that testosterone replacement in patients with both treated or untreated prostate cancer is both safe and effective, particularly in men with low-risk malignancies. There's less convincing evidence that shows safety in men with a history of high-risk malignancies. So if someone has a high-risk prostate cancer, they wouldn't do it. In men who are symptomatic, it may be safe, provided that there's good surveillance.
Okay. And if somebody has low testosterone, they have symptoms, do they have to do anything about it?
Testosterone is not one of those life and death things. You're not going to die from having low testosterone. It's a quality of life issue. So it all depends on what kind of quality of life you expect and what you want. So if you do nothing at all, we're fine with that. It's up to you. And so if our patients tell us, no, I don't want to treat this, we're good. And then if they change their mind later on, great. If not, there's so many other things we can address. In every single podcast we've done so far, we talk about lifestyle, diet, exercise, all that. That takes precedence.
Is there an age limit on when you can treat somebody, or is it ever, quote unquote, like too late?
I would say there's no age limit. Anyone who wants to be treated should be given the option to be treated.
Unless you're young and of childbearing age, and that's in the picture, then we'll talk about that. So what about somebody on hormone replacement therapy? Do they necessarily need an estrogen blocker?
It's a common thing that a lot of testosterone clinics do. We typically don't unless someone has a lot of conversion of testosterone to estrogen and they're symptomatic with it. Then we will. But you need estrogen. Men need estrogen just like women need testosterone. And when you block too much of the conversion to estrogen, that's when you start getting the mood swings and things like that.
So how does somebody get off of testosterone if they want to start a family?
Well, we already said before that testosterone can decrease the sperm production in the testes. So people have a harder time getting pregnant when they're on testosterone therapy. So typically we plan ahead and we tell people, when you're planning on starting a family, we're going to stop you quite a ways before you reach that point. It's been shown that HCG injections can help replenish or bring the sperm production back. And typically, I think it's going to be about 3 months or 3 to 6 months. Depending
on the protocol. Yeah. You can get it sooner. And as well as, obviously your lifestyle modifications. And there's also a peptide called kisspeptin. And that one is also great at working for fertility. But along those lines, let's talk about how can somebody increase their testosterone naturally?
Yeah. So if you don't want to take testosterone, there's still other things you can do. Lifestyle modification.
So a big part of this is, as we already discussed, the circadian rhythm with sleep. So sleep is critical. You need good sleep, 8 hours. You want to make sure you're not having sleep apnea, which would be a depletion of your oxygenation while you sleep. You need to make sure you have reduced stress intake overall, and you need to do things to get you out of that quote unquote red zone, the flight or fight, so you can relax, so the body can relax. Also, you need to get moving. You need to exercise every day. That will increase it, and resistance training is critical, as well as proper diet, eating healthy, and trying to avoid toxins, like we said before, plastics, fragrances, BPA, things like that. But there's also some supplements that we can do, or medications as well, that are not hormone replacement therapy options, but they'll help boost. So tell us about aromatase inhibitors. I know these are small amount of circulating testosterone is converted to estradiol and through something called aromatization. And so aromatase inhibitors are what?
So aromatase, also called estrogen synthetase, is an enzyme that's responsible for a key step in the conversion of androgens to estrogens. And aromatase is typically found in fat cells, and it's found in people who are overweight have higher conversion rates. So estradiol is the most potent estrogen produced in the body. It is synthesized from testosterone or estrone via aromatase, and roughly 60% of circulating estradiol in men is derived from direct testicular secretion or from conversion of testicular androgens.
And so aromatase inhibitors may increase testosterone levels in men by increasing levels of the bioavailable testosterone, which you talked on earlier. So by lowering the estrogen levels, this can subsequently increase the levels of FSH and LH.
And it's questionable whether aromatase inhibitors really stimulate a lot of testosterone production in men with truly low testosterone levels, unless they're overweight. So this typically works better in obese men. And some examples of commonly used aromatase inhibitors are anastrozole and letrozole.
Okay. And so DIM, you mentioned that before. So DIM is diindomethane, and it's a compound found in cruciferous vegetables like broccoli and cabbage or cauliflower.
DIM is something that we in our practice put every testosterone replacement patient, male and female, on. Typically, we use higher dose in male than in women. And it showed anti-inflammatory and anti-cancer effects in laboratory and animal studies. It was also shown to increase bone mass, which may help patients with osteoporosis. And DIM is able to support free testosterone without changing total testosterone levels. It does not raise testosterone levels, but it supports its activity through the effect of aromatization, and it helps maintain healthy levels of free and active testosterone, which is why we use it in especially our pellet patients, but in all our testosterone replacement patients.
And tell us about clomiphene citrate.
So that's FDA approved only for use in women, and it's used off-label to raise testosterone levels in men who wish to, especially men who wish to raise their testosterone levels but still preserve sperm counts. And I get this a lot from pharmacists when I write a prescription for clomiphene for a male patient, and the pharmacist tells the patient, nope, that's only for women. You're not supposed to be on it. That was a mistake. Well, it's not a mistake because it actually does help. And we also use it in our younger males. It's a selective androgen receptor modulator. It blocks estrogen receptors in the hypothalamus and in the pituitary. And it antagonizes the negative feedback of estradiol and therefore causes an increase in LH, FSH, and ultimately those cause an increase in testosterone levels. It can potentially increase testosterone levels for up to 3 years. I typically don't keep people on it indefinitely, 2 to 3 years at the max. And the typical dosing that we use is 25 milligrams of clomiphene 3 times a week.
And some other alternative options out there that I think a lot of people, the greater population might not know, is peptide therapy as well, such as growth hormone analogs, CJC ipamorelin, sermorelin as well. Those can cause as you might have noticed, like a lot of these just increase your testosterone levels indirectly, right? And they can do the same. So why is testosterone a controlled substance?
And this is something that makes no sense to me. I really don't believe testosterone should be a controlled substance. In the United States, all testosterone is classified as a Schedule III controlled substance, and this was largely due to its potential for abuse by athletes and bodybuilders. And that's not to say that the general population is going to be abusing it. And the passage of the Anabolic Steroid Act of 1990 named testosterone an anabolic steroid, therefore making it a controlled substance. The AMA, the FDA, and the DEA all opposed the classification of anabolic steroids as controlled substances, and they believed that the original purpose of the Controlled Substance Act was to provide more strict regulation regarding drugs that are psychoactive, which testosterone is not psychoactive. So that's something else that hurt the overall thinking of testosterone and decrease the ability of people to get testosterone.
So I think this was a very informative session today. And as we mentioned, you can feel free to contact us, ask us any questions, and we'll do our best to get back with you. Until next time, thanks for listening.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.